you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
Hello, Ultrasound Podcast listeners. Matt here. Fluid responsiveness is a hot topic. We recorded a couple podcasts on this and released them with our thoughts about a year and a half ago. However, it turns out others have thoughts too, and a debate raged on. You may remember an episode on the podcast from October last year with Haney Malamet and Mike Stone, in which Mike said this.
So I don't know. Maybe it needs to be done. I at this point I don't even like this IVC. I want to get rid of it. I want to take it out of the body.
Cut it out.
Okay, so shortly after this, just a few weeks, there was a response by the good Dr. WEINGART and EM Crit, where Scott had the following to say.
And then they got to the topic of IVC ultrasound for fluid responsiveness. And the two of them bashed IVC ultrasound. And I was just dismayed by the fact that two ultrasound gurus just got it so wrong.
Wow. So the normally very reserved, quiet Dr. WEINGART felt pretty strongly about this. And both Drs. WEINGART and Stone were teaching at CastleFest, and we had a fluid responsiveness spot to fill. Well, you know us. We absolutely couldn't resist. Instead of having one teach, we decided to split the time and have them go back to back. That's right, the rumble in the castle. Here it is. Let's get ready to rumble.
Let's get ready to rumble!
Actually, you're only going to get part one first. Dr. Stone went first at CastleFest, so he'll go first here as well. Look for the WEINGARTian response coming up.
So, back in October of last year, I got on a video conference with Haney Malamet, who's a ED critical care guy. He's at University of Maryland. He was a former resident of mine at Kings County. Great guy. We had a couple of beers and started talking about volume resuscitation, right? Because that's what you do when you're catching up with an old friend and drinking beers on the phone.
Just to be clear here, Mike Mallon and I don't combine alcohol and podcasting like Stone does. Yes, some of the non-cardiac things Mallon says, it may sound like he's drinking. Oh, no need to roll your patients on their side when looking at the gallbladder. Yeah, drunk. But we're really not. Just wanted to clear that up. Sober Mike Stone, please continue.
And little did I know that would land me in the ring with Scott WEINGART. I think it's really funny, all the hype that's been going on about this. And I mean, even just an hour ago, here's Rumble in the Castle, IVC Smackdown. And, Matt Dawson, I think really kind of nailed it today. And when he said that we're all such ultrasound we're so evangelical about ultrasound evangelists, and we have so little to disagree on. Is it good to look at somebody's heart and hypotension? Of course it is. Is it good to look for their AAA when they're sick and they have abdominal pain? Yeah. Do you want to use it for procedural guidance? Of course you want to use it for procedural guidance. So we have to find something to argue about. And this is basically where we've landed. And the sad thing, and I hate to disappoint you guys early, is that we actually agree on most of this, but we'll try and make it entertaining for you at least. And Matt's a smart guy. I mean, he works with that guy Mike Mallon, who wrote the book and does the podcast. So, I got to assume that he knows what he's talking about. So, let's take a dose of reality, though. Scott, his whole thing is bringing upstairs care downstairs. He works in an ED critical care unit. I work right now in a big tertiary care center, but I've been in county hospitals. I've been in tiny, it's you and 3 nurses and 11 beds in a fixed-wing aircraft places where there is no upstairs, and it's a ranch hospital. So you do what you can that's going to work for patients when you have a full ED. And I think, as usual, a problem is really good to look at. I don't know if any of you guys hated physics as much when you were undergrads as I did, but I found the only way to understand physics problems was to look in extremes. So we know that if we have a sick patient, they're hypotensive, we'll say that they're septic for now, and we're presuming they're septic. They've got a high lactate, their blood pressure's low, they have a confirmed or suspected source, we need to treat them. It's pretty obvious that giving them 100 cc's of crystalloid is not going to help them. And it's pretty obvious that giving them 18 liters of crystalloid is probably not going to be a good thing either, right? We know that too little fluid is bad. You don't perfuse the organs. You start pressors at that stage, and you're back where we were with norepinephrine when it was called leave them dead, and it was 10, 15 years ago. Or you give them 15 liters of fluid, and they third space, and then maybe they end up in worse trouble, and we end up not in a good place. So we know that there's extremes, but is the ideal amount of fluid for your septic patient 3,156.2 cc's? We need to be realistic about this. If you give somebody 3 liters or you give them 4 liters, I challenge you to tell me that that's going to have a bad outcome for your patient. So use a reasonable amount of fluid, and we could probably end the talk right there. But we'll keep going a little bit further. So Scott, one of the things I really liked, aside from all the personal derogatory stuff he said about me, in his talk was this sort of concept of a bronze, silver, and gold medal for fluid resuscitation. And the bronze medal I like to firmly embrace is my medal. Okay, I'm in 3rd place. I like to empirically fluid load sick patients. I look at them with an echo first. I think the echo is important. The echo, just like Cliff said, just like what that guy who works with Mike said, is, what it does is it lets you look at the patient and say, the pump's not failing. There's good LV contractility. There's no obvious open left-sided aortic or mitral regurgitation. They don't have a giant right ventricle and we think that they have an obstructive cause of shock, or tamponade, an obstructive cause of shock. I knock those things off the table early. I look at it and I go, okay, this is somebody who is going to probably be volume responsive in some way. Here's 3 or 4 liters of crystalloid. Guess what? You're still really sick and your MAP's still really low and you're not clearing your lactate. I intubate that patient, continue with fluids, and start norepinephrine at a low dose. And I think intubating a patient who's had 4 liters of crystalloid, who's still septic, taking away the energy that's going to their work of breathing, reducing their insensible losses, I think is a totally legit way to go. Once you've intubated them, as you'll see in a few slides, none of this matters. You can pick whatever you want to find out whether they're volume responsive. Option 2, Scott's going to talk about, and I'm not going to go any further really into, but I like this. It's intriguing. It's sort of, is it safe to give more fluids to this patient? And Scott, are you going to talk about the falls protocol at all? Okay, so I mean, Scott will talk about it with respect to the IVC. Daniel Lichtenstein has this same sort of theory, which is go ahead and look at the lungs. You see A lines. Start giving fluids until you just start to see B lines, and then stop giving fluids. It's interesting. It's sort of like give it till it's safe, and then you start to see preclinical alveolar edema. Obviously, if you have ARDS or you start with pneumonia, that's going to be a limitation. So I don't know. I haven't used that personally. And then option 3, the gold medal, is to identify a fluid responder. And just so we all know what we're talking about with that definition, a fluid responder is pretty much universally agreed upon as this person. You give them 500 mLs of crystalloid rapidly over 10 minutes with a pressure bag. Their stroke volume increases by 10 to 15%. So that's a fluid responder. It's somebody to whom you give a rapid fluid challenge and their stroke volume increases, which makes sense that that would then perfuse their tissue better, and they probably could have used the fluid. There's still plenty of people who argue about whether they even needed that fluid. You could probably give any of us a volume bolus and our stroke volume would increase, but I think we'd probably be okay without it. But this is the gold standard. This is what we go by. So why ultrasound and why do we need to find measures? We could just examine them, right? We could, feel their skin temperature and, look for skin tenting and see if they needed fluids, right? Well, obviously, we all know we can't do that. So, in terms of the physical exam, it's markedly limited. You're not going to stand your patient up and do orthostatics while they're septic, and you're not going to know whether they're fluid responsive. And again, it's really, this is a problem, I didn't really mention this, but this is really a problem that's sort of day 2 in the ICU. When everything, all those bad humors start to swirl around, and the heart's having myocardial depression because of sepsis and cytokines. There's vasodilation. There's also just plain old hypovolemia. And you don't know where you are in that sort of array of things that are happening. When you first see the patient in the ED and they're hypotensive and they don't have pump failure, they're not obstructed, just give them a bunch of fluid. It's okay. What about echo? Well, we could use echo for a few things. And if you look, what do you guys think about this EF? Mumble, mumble, mumble. Good, it's good. It's hyperdynamic, right? The walls are touching. The left ventricular walls are kissing here. This is somebody who clearly you're going to feel very safe about giving fluids to, and you're going to want to aggressively resuscitate them. The problem is when you see this. And this person clearly has a pretty crappy EF, and yet you have no idea if they need fluids or they don't need fluids. And if you look at this person's vena cava, you have a good chance that it's going to be nice and fat and plump, and yet they still need fluids. And my whole diatribe about the IVC is that I think it's dangerous to look at it, see it as not flat or not collapsing, and say, that's fine, this patient doesn't need fluids. I think we lose the opportunity to aggressively resuscitate patients. So CVP, I think Cliff really covered this better than anyone. Don't use it to make clinical decisions about fluid responsiveness. So we're not using CVP. And CVP is really just emblematic of static measures of fluid responsiveness. It's a single picture of what your body's doing. It's not dynamic. And we all know that a single picture doesn't tell the whole story as well as a video, right? So, and those are my boys. They're both still okay for now. We need to talk about ventilation, okay? Why does it matter whether they're ventilated? Well, you can go ahead and go over to the PACU in your hospital when you get home. You can walk into the PACU with your ultrasound system or borrow theirs. You can look at somebody who comes out of the OR who's gotten plenty of fluids in the OR. They've measured it meticulously with their urine output and their ins and outs. They're 2 or 3 liters up from their surgery, and they've just been extubated. And they're laying down in the PACU going as they're recovering from general anesthesia, and they've got horrible obstructive breathing, and their IVCs will collapse and touch entirely. Okay, if you have someone who's really generating high negative intrathoracic pressures with their breathing patterns, you don't know what that means with their IVC. It's much harder in an uncontrolled, spontaneously breathing kind of population. When you intubate somebody, sedate them adequately so they're not breathing on their own, you deliver 8 to 10 cc's per kilo of tidal volumes in a controlled setting on AC, and you go ahead and measure these things like IVC, they work really, really well. And in fact, you could pick kind of whatever you want if they're ventilated. You could use bioreactants, bioimpedance, you could use a bunch of things that are probably more familiar to you guys by their trade names, but I'm not going to mention them. You could use pulse pressure variation, stroke volume variation. You can look at the IVC. It's kind of tough, and Scott and I will admit that neither of us, even in intubated patients, use the IVC because nobody wants to sit there trying to figure out if it's 13% and doing these tiny little measurements, but it has been validated and it does work. So anything's fine once they're intubated. And I guess my whole perspective on this is if somebody's so sick in the initial ED encounter, I know it's not obstructive, I know it's not left-sided failure, I'm treating them aggressively with fluids because I know that's the problem to start with. They don't get better after a reasonable fluid bolus, 3-4 liters of crystalloid. I'm going to intubate them because I need to take away their work of breathing and focus on the patient, the vital organs, and let the lungs take a rest, and let them divert that energy that they're creating into different parts of their body that need it. So this spontaneously breathing thing, I think it's overblown. Options in spontaneously breathing, well, we have maybe IVC as a potential option, and then we have looking at what happens to your stroke volume and your cardiac output. So why hate on the IVC? It's easy, really, and I have to say, so he's an unsung hero of this conference, and he's not here right now, but Jody, who's been sitting in the back where that guy who works with Matt Dawson, who does the book, is sitting right now. He is it's sort of dangerous to be around Jody. I turned to Jody yesterday at like 2 in the afternoon and said, wouldn't it be awesome if I could get a video of the IVC and put Scott's head in it and then have it crush him and he could make funny noises? And he was like, oh, give me 10 minutes. So, that'll be up online by itself later for you, Scott. So Jody's, you got to be careful when you have somebody like that around because these perverse things that pop into your mind, he makes them a reality. But he's really responsible for this Castle Fest not being more of a flail than it is. So what are the limitations with the IVC? Well, if you're going to do it and you choose to do it, and Scott's going to probably convince you guys that it's worth doing in certain cases, predominantly if you don't just have the chutzpah to give 3 or 4 liters without knowing. But IVC displacement during respiraphasic ultrasound imaging, this is why you don't use M mode. Okay, this is what happens. This is on the left panel, cranial caudal movement of the IVC with respiration. The diaphragms move towards the feet when you breathe in. You shift the whole IVC down towards the feet, and you're measuring 2 different areas of the IVC in M mode. So if you're going to do it, at least use B mode, freeze it, cine back, measure at the same location, and at least it'll be a little bit more scientific than using M mode. In ventilated patients, you don't see that degree of excursion. It's fine to use M mode if you want in ventilation. What about inter-rater reliability of IVC ultrasound? These are ultrasound fellowship trained people, and they can't agree on how much it collapses. Okay, and these are people who really know what they're measuring. So are you off axis? Are you perfectly in the middle? Is the patient positioned differently in the space of 2 minutes that you go back and forth? I don't know, but we know that it doesn't really correlate that well. So it's not accurate, and it's not reliable. So it's probably not the best thing for us to look at. This was a study that we looked at in healthy volunteers, and all we could tell was that measuring it at the hepatic level versus at the renal level versus at the diaphragm, you got different measurements. We don't know which one of these is a right measurement even. We had no gold standard here. We just know that it varies on where you look on the IVC. So you probably want to standardize it somewhere if you're going to use it and make sure you use the same place. Now, here is a great study. The Barbier study gets quoted all the time. On the left are intubated patients, and on the right, intubated patients. This cardiac index charts. If their IVC collapsed more than 18%, they all responded to fluids. And remember, it's actually distending with positive pressure, not collapsing. But if the variability of the IVC, the delta IVC, went up by 18%, then guess what? They did well with fluids. And if it didn't go up that much, none of them really responded. So in ventilated patients, yes, it has value. If you want to sit there and calculate 18% and get your calculator out and do it, that's a totally valid way to look. You could also use bioreactance, bioimpedance, pulse pressure, stroke volume, all these other things that work great. Now, right atrial pressure, those charts, and I love the chart that Cliff put up the first day of sort of, if it collapses this much, your right atrial pressure is 5, and if it collapses this much, it's 5 to 10, and if it collapses that much, it's bogus and it doesn't work, and it's been refuted in multiple studies at this point. So please don't pay attention to any of that. Don't look at the IVC and say, oh, their CVP is 6, because I see what their IVC is doing. It may have a role in trauma, and as much as I'd like to hate on the IVC, you look at the people on the left and in the controls who did pretty well versus the shocky patients, people who, and this is just diameters, this isn't even collapsibility index, but you look at somebody and their IVC is completely flat, slit-like, it's like a pancake, and they're in hemorrhagic shock, those people probably have higher mortalities and need more aggressive blood volume resuscitation early. So it may have a role in that setting, but that's not who we're talking about. We're talking about the septic, vasodilated, maybe some cardiac stuff. We don't really know what's happening and how to treat them. We know how to treat massive hemorrhagic shock with massive transfusion. This is a paper, and I had to bring this one up because this is a paper that Scott mentioned as why we really are seeing some positive stuff about IVC mechanics in spontaneously breathing people. But low variations don't rule out a need for fluid therapy, and that was their finding. And you look at this paper, number one, I'd call attention to the fact that it's about 20, 30 patients, so it's a small sample size. On the left are responders, on the right are non-responders. That dashed line across the middle is 40% collapsibility. You look up at 100% collapsibility. There were about 8 people with 100% collapsibility who responded. There were still 2 or 3 who had upwards of 80% collapsibility who didn't increase their cardiac output with fluids. And even more concerning, and the reason why I started to kind of preach about this and why I think that it's dangerous for us to rely too much on it, is the bottom. On the bottom, you've got a bunch of responders who don't collapse.
Sorry to interrupt, but can I tell you why I love this debate? In the world of bedside ultrasound, there's absolutely no one who I trust more than Mike Stone. If I have to have the correct answer to a question I don't know, I'd ask Mike Stone, unless it's cardiac, Malin, don't yell at me. And in the world of critical care medicine, if I had to have the right answer, there's absolutely no one I would trust or go to more than Scott WEINGART. So the fact that these two guys disagree on this critical care ultrasound question is awesome. Some people would call it maddening, but I think it's brilliant. It's a stunning reminder that we don't have everything in medicine figured out. I've been practicing not that long, and I've already found several things that I thought I knew that I was just wrong about with new evidence. The key is to embrace it instead of cringe about it, so enjoy this debate. Don't worry, we're not going to focus on the debate forever, though. We'll continue to also give you the hard facts, the things that we're certain of in ultrasound, or at least we're pretty sure of. I mean, they're probably right.
Okay? And they don't collapse their IVCs, and yet if you give them fluids, their cardiac index goes up. So just don't be reassured by an IVC that's not collapsing a lot that you're done with your fluid resuscitation. And I think it's just a word of caution. Spontaneously breathing patients with septic shock, here they are doing M-mode measurements. So this is, again, just to call your attention to the fact that this literature isn't great. We know that these are 2 different areas on the IVC that they're measuring, and yet this is the study they're publishing. And you look at this one, and let's see, there's about 8 patients in each group, and the results are totally variable. So it's an unknown quantity in spontaneously breathing patients. In intubated patients, I think it works really, really well as one of many options that you have. Now, you guys have heard us bat around the term vaginal all day, and that's because of Cliff Reed, and Cliff has actually tweeted the vaginal challenge because he thinks that we're really intrigued with the way that Australians and British people pronounce vagina. So in honor of Cliff, if the IVC looks like the vaginal stripe or the vaginal stripe, then you probably will be fluid responsive. It's completely flat. You can go ahead and give some fluids, and that's fine. Totally inappropriate, but I told him I'd put it in. So what about stroke volume? Stroke volume, Mike did a nice job covering, And we know that it's your LVOT area times your VTI. You get that fixed orifice that things flow through, and you look at how much length of the blood flew through. Why the LVOT? We use the LVOT because it's a structure that we assume doesn't really change much in size with systole and diastole. You can also do it with the aorta, and if you couldn't get a good view of the heart from a apical 4, you could do a suprasternal notch view and look at continuous wave velocities in the aorta. There's lots of ways you could get a VTI. We could measure the stroke volume, spontaneously breathing patient. We could either passive leg raise them, which is a pain in the butt, and it does work. It's fun to show to students. Or you could do even better, 500 cc's of crystalloid on a pressure bag over 10 minutes, just like we talked about as the standard definition. So you get that stroke volume, you bolus them, you measure it again. If it went up by 10 or 15%, do it again. Okay? You've just determined who's fluid responsive. But does the stroke volume increase by 10%? That's what we're asking. We know, as Mike pointed out, who cares about the stroke volume? We can do this exact same thing, and we can eliminate the LVOT area from it because it's a linear relationship. So we can just say, what's your VTI? It's 19.35 centimeters. 500 cc's of crystalloid over 10 minutes. Remeasure the VTI. If it went up by 10 or 15%, you responded. That's a really simple way to do things. Is it as simple as getting a view of the IVC? I don't know. But in a spontaneously breathing patient, it's a lot more accurate. So if you feel like you need something to go with and you don't feel comfortable giving somebody 3-4 liters of fluid because you think they're in shock, which I feel comfortable doing, and then if they don't get better, intubating and taking control of their airway, taking it out of the equation, and using whatever else you want, then this is one way you can go. So measure the VTI, bolus them, and measure the VTI. That seems pretty straightforward, and it seems like something watching you guys work in the labs over the last 3 days, all of you guys can go do that. Everybody's getting an apical 4. Everybody can put pulse wave over the outflow tract and measure a VTI. So pretty straightforward, pretty manageable to do. Wrapping up, dynamic measures are way better than static measures, and you shouldn't rely on anything static. Don't rely on the dimension of the IVC, the diameter. Don't rely on CVP. Look at something and how it changes with the respiratory cycle. Understand the difference between ventilated or not ventilated, because that's really where all these arguments and controversies come up, is in the spontaneously breathing patient who's so sick that you're agonizing over volume responsiveness, and in my ED, that's an intubated patient. Choose your tools. If you want to, once you intubate them and do the right thing, you can go ahead and use pulse pressure, all the other commercially available things you can do to look at cardiac output. And that's what I got for you guys. Thanks so much.
Well, there you have it. Well articulated, supported by the literature, great education by Mike Stone. But we're not done. Oh no, Dr. Weingart has something to say. Stay tuned. In the meantime, don't forget to register for CastleFest 2014. Both Stone and Weingart will be there again, and we'll continue duking this out and find out if any new evidence has came out and figure out if anyone has changed their mind. Hope to see you there.
Hey everybody, Mike here. Look, don't tell Matt I'm doing this, but you guys should all consider doing an ultrasound fellowship at the University of Utah. Pay really well, and it's a great place to live, and it's an awesome opportunity to do a fellowship, much better than trying to live in some place like, I don't know, say for example Kentucky, where they pay you well, but I mean, God, can you imagine your quality of life having to deal with somebody like Matt Dawson on a daily basis? Terrible.
Okay, everyone, if you're listening to this, don't tell Mike I added it on to the end. He doesn't listen to the actual podcast, so he'll never know if you just keep your mouth shut. I wanted to invite graduating residents who listen to this podcast to apply to our ultrasound fellowship at the University of Kentucky. The fellowship is in its first year, and it's going awesome so far. We've got a great fellow, and I want another one next year. I wanted to specifically speak to you all, though, because I want someone who listens to podcasts, who is committed to learning and being as incredible as they can. I'm going to be very blunt with you, though. I want future leaders in point-of-care ultrasound. If you need a lot of hand-holding, then this may not be the program for you. I'm going to give you everything you could possibly need to succeed, but I want someone who is committed to making a difference and shaking things up from day one. I'm the medical director for point-of-care ultrasound for our entire university hospital, so I want someone who not only is passionate about emergency ultrasound, but who also is passionate about spreading point-of-care ultrasound to the whole house of medicine. We work with every department in the hospital and provide leadership to a vast diversity of physicians and providers. So if you want to do something huge, then let me know. You can see more info about our program at eusfellowships.com and also apply there. Email me at matt@ultrasoundpodcast.com and we'll talk. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.